Hi, everyone, and welcome to ABCs of Anesthesia on the podcast and YouTube. So we're going to be talking about volatiles, and again, we want to get you really, really important information, practical information that you can just listen to on your drive to work, especially in your first rotation of anesthesia. So we're going to cover volatiles, what to use, how to decide what to use, nitrous, pentarain, sevoflurane, DES, isoflurane, and then a few different situations like gas inductions, breakthrough parenteral regional anesthesia, and some of the environmental stuff and risks as well. So let's get started. I'm Lahiru.
Hey, I'm Kaz.
And usual disclaimer for this is all just general information. Please don't use this for any particular patient. Consult your team, consult your supervisor, and make sure you're considering each patient's circumstance in its own context. So, Kaz, what volatiles can we use, and what can we talk about today?
So there's a number of volatiles that are available commercially. In Australia, the most common ones that we would use are sevoflurane, desflurane, and nitrous oxide. Other agents you might hear about are isoflurane and pentarain or methoxyflurane, which is used predominantly for analgesic purposes now.
Excellent. And so we don't want to go through all the pharmacodynamics and pharmacodynamics, but there's a couple of important things. So what do you reckon the essential pharmacokinetic things are that every junior needs to know about?
Look, the main things you need to know is the blood gas partition coefficient. So this is a measure of the solubility of the agent. And again, there's a bit of the complex pharmacokinetics, but this essentially affects how quickly the drug has its onset of effect. So the blood gas partition coefficient, and then the MAC value, which is a measure of its potency, essentially, which is more of a pharmacodynamic.
Beautiful. And you've just done your first part, so you know so much of this information, but essentially low solubility, so low blood gas partition coefficient equals fast onset and fast offset, which is not that intuitive. We won't go through all the details of that, but that's all you got to remember. Low is fast onset, fast offset, which is generally thought to be pretty ideal. Okay, Kaz, so I want you to rank the agents. What's fastest, what's slowest?
So in terms of fastest to slowest, we have desflurane, followed by nitrous, sevoflurane, and then isoflurane.
Fantastic. And then the other important thing is, I guess, metabolites, but this rarely comes into effect because essentially, they're all very minimally metabolized, like anywhere from 0.2 to 2 to 5% with sevoflurane, and 0.02 for desflurane. And then the worst one is like halothane, which is 20% metabolized, and that can cause hepatic failure in rare instances. But again, that's not something we use at all in Australia anymore, at least in human medicine.
Exactly.
So imagine that's all the pharmacokinetics which we think is relevant to your day-to-day practice. Now, we were going through pharmacodynamics, and really that's just your MAC, your minimum alveolar concentration, and some greenhouse gas stuff. I mean, all of them are hypnotic. Some of them have analgesic properties, but really they often drop your blood pressure and drop your contractility. And you really got to watch those things, and maybe your ICP stuff. But these aren't day-to-day important stuff. So what do you reckon? What are the MAC values? And then we can talk about greenhouse gas effects.
Yeah. So I guess to kind of recap some salient points. So the mean alveolar concentration the minimum alveolar concentration is the minimum concentration required to prevent a movement to a surgical stimulus in 50% of patients. So this is.
And it's really interesting that they were so specific with that definition.
Yeah.
A standard surgical incision on the forearm, reflex movement, not just voluntary movement. So the patient's asleep anyway. And the age range was like 30 to 50 years old, or essentially mean at 40 years of age.
And it's a really new concept, isn't it? So Eager was kind of the pioneer of the concept of MAC, and he only really did it in the 40s or 30s. So compared to a lot of other things in medicine, it's a relatively new concept, and I think it really revolutionized how we use it. And unfortunately, I think he died a few years ago. He was really impressive gentleman. So look, in terms of the MAC values, so I like to think of these as the ways we predominantly use them. So isoflurane has the lowest MAC at 1.17, followed by sevoflurane, which is 1.8. Desflurane is 6.6, and nitrous oxide is 104%. So these are all in percent. So I guess the salient things here is nitrous oxide is 104%. That means you need more than 100% to reduce movement to a surgical stimulus in 50% of patients. So the key point there being it can't be used as a solitary anesthetic agent.
Unless the patient's really old, so elderly patients. What is it? There's a 6% per decade reduction of MAC. So, if you're an 80-year-old, your MAC is 70% roughly of, a person at 40 years of age. So I thought that was pretty,
that's a really good point.
Yeah. So yeah, there are definitely times, and we go into this because you don't want to be using nitrous too much because of its greenhouse gas effects. And we really need to be, so mindful of that, especially in this day and age. But, sometimes you'll give nitrous to an elderly patient and they'll be out. And you're like, well, I didn't realize nitrous was that effective. This is just laughing gas.
Yeah.
People used to just use it for entertainment and it's just knocked out my patient. Okay, so that was interesting. So your values, so, SIVO is 1.8. And on my machine, I've dialed up to 2.1% end-tidal volatile concentration, and I swear it says 1 MAC, and that's what I've been using this whole time. So I've been completely humbled in this discussion because for so long I've been using the 2.1 as my 1 MAC value. Yet, one of the textbooks that we really use a lot in anesthetics, Peculiar and Williams, Pharmacology for Anesthesia and Intensive Care. This is where I go for most of my information. They've said 1.8 as well, so I'm gonna have to change my values. This is devastating.
It was an interesting conversation because it's one of those points where I kind of stopped and went, oh, have I just been saying the wrong number for the entirety of my exam? But we also checked in Miller's, which is the at least for the part one is what you kind of is the argument breaker in your study group. Whenever you have a discussion that you can't agree on a value, you go to Miller's and you just assume that's what the college accepts as fact. Yeah, so I actually think it'd be pretty interesting if anyone knows why the anesthetic machines say 2.1 and can let us know. I think that'd be really interesting to find out.
Let us know. anesthesiapodcast@gmail.com. Let us know. So practically speaking, we dial up the sevoflurane or the volatile that you're using, and then your end-tidal volatile concentration, not your inspired, but your end-tidal is roughly what's going to be at your brain at steady state at equilibrium. So your end-tidal volatile should be around 1 MAC or 2, let's say 1.8% SIVO or 6.6% DAS or whatever it is. And that way, that your patient's you're going to be unaware, but also not moving to stimulus. Now, there's a lot of movement in this. Like sometimes you don't want to use that much MAC in sick patients. Sometimes if the patient's paralyzed, you don't need to use that much MAC as well because, they're not going to be aware at above 0.7 of MAC. But we're not going to go through too much of that in detail. Practically speaking, get to that 1 MAC value, turn up the end-tidal to make sure it's roughly a MAC, roughly approximately 2% in SIVO or 6.6 in DAS, and your patient will be okay, providing that you're supporting the other things.
So let's deconstruct that a little bit because I remember being a resident and being very confused about this. So when you say dial up to 1.0 MAC, what do you mean? Because I just told you that the MAC of SIVO is 1.8. Can you reconcile those numbers for people who might not know the difference?
Oh yeah, so when you'll get two values that are important. The end-tidal volatile, that's the percent that's going to be in your body at your brain. And then you've got a calculation, which the computer in the anesthetic machine then tells you what the MAC is. So that'll be, anywhere from 0 to 1.2 MAC. So when I do the anesthetic, I dial up the concentration of CO. So I might start with an inspired concentration of 4% with flows of, 2 liters or something after induction, 2 liters per minute. And then that will slowly build up in the body. So my end-tidal will slowly build up to, the 1.8 value or the 2% value, depending on what you're using. And then the computer calculates that 1.8% end-tidal volatile as 1 MAC.
Yeah, good. That still I think confuses a lot of juniors. So you breathe in the volatile, it goes into the body, and then you breathe it out. So your end tidal is the measure of how much it's how much volatile is in your tidal breath. So it's how much is being breathed out. So it's a measure of uptake. So your end tidal, as Lahiri said, we use as a surrogate measure for how much is in the effect side or the brain. And the closer those numbers get together, the closer you're at equilibrium. And the MAC value. So, we also often say we run a patient at 0.8 MAC that has a corresponding end-tidal volatile value. So while the definition of 1 MAC is a percentage of a volatile, the MAC itself becomes a unit, then we can then titrate, which has a corresponding end-tidal value.
Yeah, I think that's really
Does that make sense? Yeah,
that's well explained. So that's MAC, and you'll get very familiar with it literally in your first few days. It'll be easy. How about the greenhouse effects? Because this is not something I thought about when I started anesthetic training ages ago. but the awareness of this and trying to actually make a difference. Now, we've got a real fantastic champion of this in our department, Forbes McGain. He's just done so much great work in this, and he knows so much about this, and he really changed the way I practice, because I don't use desflurane at all. And one of the things he mentioned was, using desflurane at 1 Mac at 1 liter per minute is like driving a Hummer, one of those big, military style cars, very energy inefficient. It's like driving that car at 200 kilometers per hour. And when I think about that, I think, oh my God, that's a terrible use of an agent, especially if there's far better agents to use, or I don't really need to use des for a fast onset offset.
Exactly. So, volatiles kind of are well known for being environmentally unfriendly, but they do have their roles, and I think it's kind of the awareness and careful use of the drug. So I don't think it's as simple as to advocate for complete omission of volatiles. It's actually very complicated, because when you use TIVA, you use a lot more plastic and a lot more tubing, and you use electricity for the pumps, and all these things actually add up to be quite significant. So the conversation isn't as simple as we once thought it was. But if we think about just the volatiles, so we were talking about this earlier. So there's two main things you need to think about. There's global warming potential. So this is how much global warming an agent causes in comparison to a similar mass of CO2. And this is really to do with the reflection of the infrared radiation from the Earth. And then there's ozone depletion. So this is essentially how much damage can be caused to the ozone layer compared to a similar mass of trichlorofluoromethane, which is CFC, which is in all those spray cans.
That's so good. Like I actually had no idea of this. I'm so glad you were teaching me this, that there's these, and it is so complicated. The environmental impact of stuff is so complex, but it's really great to actually know those two things. Global warming potential, was it? And ozone depletion. Excellent.
Exactly, yeah. And the two main culprits are des and nitrous, and they actually affect these differently. So desflurane is, the main global warming potential agent. It's 2,540 grams per gram of CO2. So it's 2,500, and it's 20 times compared to SIVO, exactly. But in terms of ozone depletion, nitrous oxide is the main culprit. And this is why I think a conversation about nitrous oxide in theatre and also out of theatre is again really important about these effects. And I guess, to a lesser degree, there's local environmental effects. So risk to theatre staff, teratogenicity of both nitrous and SIVO in first trimester is also a risk as well. But I'm not entirely sure how proven that is, but I think that's also a consideration.
And so that is interesting. So again, there's a very big conversation about what you're going to use. But if let's say you decide that you need a volatile, then you can definitely decide on a better one than the worst one. So, SIVO, if you really, really don't need a fast wake up, or the wake up is not, clinically that significantly faster, like it's a minute or two, what really is that going to make a material difference at all? No, in fact, then you SIVO. But if you're thinking about whether you want to run propofol for the whole case or volatile, that's another conversation. It actually gets very complicated when you do the carbon analysis on that. Okay, so the other pharmacodynamic things are very relevant. Most of anesthetic agents will decrease your blood pressure, decrease your contractility, and you'll need to support that in every way possible. Often you'll be running a bit of aramine or giving bolus doses of that. Maybe you, in more sicker hearts, you'll be giving ephedrine to promote contractility. Those are pretty much those things. Oh, and the final thing, it inhibits hypoxic pulmonary vasoconstriction, which can be a problem if you're having one lung anesthesia. So you might want to run propofol instead of volatiles for that reason as well.
Yeah, that's again another interesting conversation which Stan loves talking about. So I think this actual reference in Miller's was only on rats. There's actually no human studies confirming changes in pulmonary vascular resistance.
Fantastic.
But it's still something that you do practically. So what did you say about that?
If anyone wants to do that project, do that research, please contact Stan.
It's a good PhD.
That's good.
I guess the other relevant pharmacodynamic effect is the airway irritant nature of desflurane.
Oh, absolutely.
Yeah. So so desflurane is a irritant. It's an airway irritant, so it can cause bronchospasm and breath holding, particularly in pediatrics. So I guess the main thing really is that it's not suitable as a solitary gas induction agent, and you can get yourself into lots of trouble if you do. But I haven't really seen it when it's been used in kind of normal concentrations for a case, but I think in an asthmatic, you'd be really brave to test your luck with whether that could happen.
Yes, I mean, I completely agree. Desflurane is not really for gas inductions, and for LMA anesthetics, generally speaking, you're not using it for LMA anesthetics. So that's the practical side of things. Most people are doing gas inductions with sevoflurane, and then LMA anesthetics are almost universally sevoflurane in this context. In other countries, maybe isoflurane. Okay, shall we go through some clinical scenarios? That's what you guys are here for.
Good. So in terms of common scenarios, so let's go back to your first day as a resident. You're doing your first ever case. So the most common thing we do is we do a IV induction with propofol, and then we wash in sevoflurane. So do you want to kind of talk us through your process and how maybe someone who's new to anesthesia can conceptualize what we actually do there?
Yeah, and it is quite peculiar. Why are we using propofol for the induction and then running volatile? And that's a really good question. So essentially, propofol is very quick. You go through the excitatory stages very quickly. So it's a very quick, safe induction. And then, you can treat the blood pressure as normal. So you get the patient off into anesthesia at adequate hypnosis quickly with propofol, but then you want to keep them anesthetized, keep them sedated for the rest of the case. And you got a couple of options. You can keep running the propofol, or you can give volatile. Now, there's definitely advantages to both, and we've gone through that in the hypnotics IV induction agent section. But propofol, great for various things, but it's great for pure NV. Maybe has a benefit with cancer patients, but you can't measure the concentration that's in the effect site. So you don't know what's actually the concentration. You've got some modeling, you've got some fancy machines and your SIN drivers and pumps that can tell you maybe what the mics per mil is, but you're not really sure. Because you can't repeat its sample. But volatiles are amazing. They go into the lungs, they go to the tissues, they go to the effect site with it, which is the brain, and then the patient breathes that. And after breathing it out, your machine will then calculate the concentration. And this is fantastic, right? So now you can know exactly what the concentration is at the effect site. That means that your patient is asleep, you're measuring that. And there's very good evidence that, above 0.7 of a MAC, there has been no case reports of awareness in patients. Whereas, let's say your propofol is running in your drip, in your vein, it could tissue. Maybe maybe the arms are tucked in. Maybe you're not seeing where it's going. There is a, theoretically slightly higher risk of awareness in those patients. So you might want to put a bispectral index monitor on more readily for propofol cases.
Exactly.
I think that's basically it. It's easy to measure. It's titratable. It's very titratable. It's very predictable and very familiar to use. Most people do induction with propofol and then volatile for maintenance.
I think that concept of predictability and reliability is really important. So there's a lot less pharmacodynamic heterogeneity in the use of sevoflurane than propofol. So, I think everyone has a story of like a little, 40-kilo adult who just chews through hundreds and hundreds of milligrams of propofol just for an induction. And it's really quite difficult to predict in a lot of cases how much propofol someone will need if you're running a total intravenous anesthetic or even really for an induction. So sevoflurane, on the other hand, has much less heterogeneity and is a lot more reliable. So I generally, as a relatively junior registrar, I generally run Sevo after hours for emergencies all the time, just because it's so predictable. It's easy for me to manage because there's a lot going on. And I think that's definitely one of the pros of using sevoflurane.
Yeah, one less
or volatile. Sorry,
one less thing to really think about, isn't it?
Exactly. So let's get in the trenches, Lahiru. So you're doing let's say we always do lab collies, but it's such a straightforward operation, I guess. So you have a 40-year-old gentleman who's getting a lab collie done, otherwise fit and healthy, weighs 70 kilograms. The quintessential perfect patient. Walk us through what you do. So we've given out 200 of propofol. They're now asleep. So what do you do now while the registrar is doing the airway? In terms of washing in the Sevo, like what do you dial it up to? What flows do you use? How do you determine that? When do you turn it back down?
Usually I'm pre-oxygenating with, say, 10 liters of oxygen. And then as soon as they start bag masking, I'll probably turn the flows down to around 6 liters per minute, maybe 4 liters per minute, turn the Sevo up. It just, again, is well patient, turn it up to, say, 4 to 5%, something like that. That washes the gas in pretty quickly, gets the...
So you're staying at the 10 liters?
I put the flows down to 6, roughly. and then turn this sevoflurane up to say 4 or 5%. Once the tube's in and secured, I will, if I don't have end-tidal target concentration kind of systems, I will literally just keep it on 4% and dial it down to 1 to 2 liters per minute, depending on what the situation is. And that what keeps the level kind of climbing. So I will develop, 1 MAC in the patient. Once I've got to 1 MAC, then roughly for, say a 1 hour case, I generally run, 1 to 2 liters per minute and have the sevoflurane anywhere from kind of 3 to 3.5% into the patient. And that would roughly mean an entitled volatile concentration of, 2%. Now, what that means is you will be able to, titrate this as required. So, don't take all of this absolute gold standard. Each patient might be slightly different. So you can just change it as required. Now, there's for well patients, sick patients, I change everything, but we don't have to go through that at this point. But everything is just less and slower because your blood pressure drops, cardiovascular compromise will be a lot more.
Excellent. And can you explain what you mean by entitled control, just very briefly?
Yeah, great question. So now our machines have these fancy kind of algorithms where you can dial what you want the entitled to be instead of what you want the inspired to be. So now I can just put, it's the start of the case, nothing much is happening. Entitled concentration of 0.7 MAC is enough, or in SEVA, maybe 1 to 1.5% is what I want. And then as the case progresses and they start doing the surgical incision, I might turn it up to 2%. So it might turn up to an entitled concentration target of 2%. You're targeting your endpoint, not the inspiratory flow or inspiratory percent.
Yeah, excellent. And the benefit of using entitled is you can then run really low flows because you know that the machine will compensate to deliver that minimum, to achieve that minimum entitled. Whereas if you're not running entitled control and you're running, say, 1 liters a minute or something, you could get the patient getting less anesthetic or even less oxygen if you're running, quite a low FiO2.
Yeah, you just have to keep a closer eye on it. The lower the flows, the more variance there will be, and the greater the distance between your inspiratory and your entitled concentration.
Yeah, excellent. So let's quickly also chat about if you have a fasted patient who's getting elective procedure, and you have a relatively kind of junior registrar doing the surgical case, so there's lots of time going for draping and things. How do you then time when you turn up do you kind of have the patient on 1 MAC the whole time and then kind of keep giving aramine to keep the blood pressure up because there's no surgical stimulus, or how do you kind of time that, and what's your approach?
I don't think I'll give any specific way because there's, I think, a big spread of practice. So if you were to keep the patient anywhere from 0.7% MAC to 1 MAC, that would be pretty standard. I think in most cases, you might have to give some aramine. There's no harm in that. You just support the blood pressure, support the cardiac output. That's fine. Yeah.
Excellent. All right. So now it's the end of the case.
Yeah.
The ports are out, the gallbladder's out there, and your boss has, gone on to start out the emergency case, and they say, Lahiru, are you happy to finish this case off? How do you go about waking the patient up? How do you time everything? Do you keep everything running until the patients, the surgeons are completely done? What's your approach?
Yeah, so look, I think when you're starting out, probably the safest thing is make sure all the surgery's done, the drapes are off, the dressings are on, and then you wake the patient up. Then that's probably the more straightforward thing for me to tell you. But you'll notice through lots of time and experience that you slowly start weaning down the volatile, as the case is being finishing. And so again, really check with your supervisor for this, but I'll keep the volatile concentration anywhere from 0.7 to 1 MAC when they're doing deep layers of suturing. So say the operation's done, they're suturing up the deep layers, the muscle, I keep it 0.7 to 1 MAC. And then when they're doing the skin layers, I get it down to 0.3 MAC. That's roughly what I do, because that end tidal is 0.3, but the brain is still higher than that. And the input is very minimal. So the surgical stimulus is very minimal. So the patient's not going to be aware because there's no big pain response. And I've given analgesia. Again, that's just personal practice. I'm sure there's lots of variance with this. When you have longer cases for stitching, like a big laparotomy requiring lots of stitching, you've got more time to wash out stuff. So, you can, there's a lot of ways you can do it. Maybe while they're suturing up the skin layers, you just keep the patient at 0.5 MAC. So there's a lot of variance in this. I'm just giving you a taste of it. Don't take my word for what you do because every case is so different. Yeah. And then there's some cases that you don't have any stitching up at the end. Imagine the ENT case where the tonsils are suddenly done or, they've done a FES and it's suddenly done. in which case you have to keep that volatile for up until the end, and you'll just have to wear the fact that you'll be waking the patient up slower.
And in terms of bringing the MAC down, so, this is one of the things where there's a lot of different ways to do it. You could, turn off the volatile, keep the flows low. You could keep the flows high and turn the concentration down. How do you conceptualize that as a junior?
Yeah, look, I think the best way, is so hard to explain it, but if you were to just try it out, that's pretty safe. For example, if you want to conserve anesthetic and not be too polluting, you just keep the flows as they are, 1 liter per minute low, and just turn the SIVO off, because there'll still be SIVO washing out. At the very end of the case, when you're actually trying to get all the gas out, then you can turn your liters per minute of oxygen up to wash everything out, but you're not delivering volatile at that stage.
Yeah, excellent. So I think when I first started doing this, I just was with a consultant who I'd worked with a lot, and I just said, I want to practice doing this while they were in the room. And it was just a nice, safe place to play around. And I think, you always have the fallback that your consultant is not going to let anything bad happen to the patient. I think that is much safer than trying to do it by yourself, late at night when you're a junior reg.
That's a great point. All of these have so much variance, and there's so much room for error, especially we think of intubation as difficult, but extubation is very chaotic. And again, I've got a video on the extubation framework on the ABCs of Anesthesia playlist. Essentially, you need your safety steps. You need to make sure your ABCs are stable, and then you've got to do reversal of the triad, have a really robust framework, and insert this method into that framework, so don't learn anything in isolation.
Yeah, great. That's a great framework that I find really useful. Good. So I guess that's a common induction. So let's do probably the less so common inductions, at least in adults. So gas induction. So walk us through your approach for this. I guess, what is a gas induction to start off with?
So how we talked about propofol, giving the injection of propofol straight to get a very quick induction into the surgical anesthesia depth. Well, you can do a gas induction as well. It just takes longer. Especially takes a longer time in adults, and most people aren't doing gas induction in adults. Essentially, it would be hard to get the patient deep enough, fast enough, and kids are far more robust. So if you would be very, you have to do 8%, or the maximum sevoflurane dose in an adult can be quite dangerous. It can be so cardiac depressant, whereas kids have a far more robust cardiovascular system. So you can dial to 8%. So let's say adult gas induction is pretty complex. I'll just leave it at that. But kids' gas inductions are often the case. There's a choice of putting a drip in and doing an IV induction, but some kids, they just don't want the drip. You can do a gas induction and have the child really, enjoying it, because you're playing a game with the mask and the balloon, and this is where they breathe on the gas, and you talk about various things. Can you smell the bananas? And you kind of play along with the kids, so they're having a nice experience, and it's an enjoyable experience, and they can see the balloon going up and down as they breathe. So you've got this whole thing happening of playing with the child whilst giving a safe anesthetic. And so literally what I do then is, most people just dial up the sevoflurane slowly. They usually have 100% oxygen on. They may use nitrous depending on what the situation is. That creates a faster inflow of the induction. And then just slowly dial it up, 2%, then 4%, keep getting the child slowly deeper, taking maybe a minute at each stage, finally dialing up to 8% in the pediatric case. And that gets them deep enough. Now, obviously you've got to worry about cardiovascular problems. So as soon as this child who's normally going to be running tachycardic, and you'll notice this, when the patient starts getting, heart rate starts getting slow, so maybe 80, even 70, then you know that your SIVO concentration is too high. And that's when I usually take an indication to dial it back a bit. There's some great pediatric anesthetists, and hopefully we'll get one on to talk about the more practical side of pediatrics, because they'll do it far more often than me. But that's probably a good basic plan.
Excellent. And sorry.
Oh yeah, and generally children need a higher MAC requirement. So often in these cases, depending on the age, you may run anywhere from 1 MAC to even 1.5, 1.7 MAC.
So I think the rule of thumb I learned with MAC was for every decade above 40, your target max becomes 0.1 less. And then for every decade less than 40, it goes up by 0.1. I think that's generally a good rule of thumb. But again,
excellent.
As you said, there's variability.
Yeah, because it's hard calculating 6%. Why not just do the 10%, roughly 10%? Is that?
Yeah, it would be roughly 10%. Yeah, exactly.
Okay.
Excellent. So look, that's really good. So I think that there's a common gas induction scenario. So let's talk about another common scenario, which is when you're doing a regional technique. So let's go back to the cesarean section, which we spoke about last episode. So you're doing a cesarean, and they're just kind of stitching up, and the baby's out, baby's safe, everything's fine, and then the patient's saying, "Oh, well, I can kind of feel something again," or they can feel a bit of pain. So what are our options here?
Yeah, that's great. So this is a very complicated situation, especially in pregnancy, and there's a lot of detail to it. But so the first thing to know is that at any stage you have to offer a general anesthetic to these patients. The fact that they're feeling pain, that's a really bad thing. Imagine being cut open and feeling all of that. That is so traumatic that you have to solve this very quickly. So again, high risk environment, call your supervisor, get help, and it can be very complicated because if they're we're on the skin layers, let's say, if they were deep within the uterus still, or the baby's not out, you wouldn't even try these techniques. You want to go straight to offering a GA because you can't just get this patient through, generally speaking, with top-ups and all these kind of half measures. But let's say a cesarean where they're suturing up, maybe just above the muscle layers or the skin, or any other regional technique without such serious issues. So an auxiliary nerve block or brachial plexus nerve block for an AV fistula repair. So it's superficial kind of operation. You can use volatiles to your advantage. So what I'd do is usually try a whole range of multimodal things, including IV analgesics that are potent enough. Things like fentanyl, even alfentanil, maybe remifentanil. Again, using them very cautiously with all their problems. Maybe ketamine, maybe giving more lignocaine into the area. But so that's one aspect of all the things you could do. But you could also use things like nitrous. Sometimes the patient on just breathing nitrous can be sufficiently analgesic with everything else that you can get the patient through this feeling and awareness of the pain of the surgery very effectively for that short time frame that you need it. Now, interestingly, you wouldn't want to use sevoflurane necessarily in the pregnant patient because they're an aspiration risk. If this patient is sufficiently anesthetized and they can't protect their airway, they lose their airway reflexes, and sevo or other volatiles are far more potent than nitrous or effective than nitrous. Therefore, they may get the patient there. That's a high risk thing, and you don't want to be doing that lightly. So again, nitrous, much safer, much less effective, and very good analgesic, doesn't get you to anesthesia that quickly.
Excellent. So I guess in a similar vein, what about procedural sedation? So, this can be in theater, can be in emergency, can be on the labor ward, for various different things. I guess we spoke a little bit about IV agents maybe last time in the procedural sedation context, but what about inhaled agents?
Yeah, and so you'll find this often in the ED context. Maybe you're doing an ED rotation, or you're on the labor ward, and they have these pre-mix concentrations of nitrous. So often Entonox is like a 50-50 oxygen nitrous mixture, or they've got other devices that you can turn up the level of nitrous in labor, during labor, so the patient has some analgesia as well. Now, so again, get in there, ask how to use it safely. Just know that nitrous is very dangerous. Therefore, it's always combined with oxygen. And I think in anesthesia, the maximum nitrous concentration you can go up to is 70%. So you've always got 30% oxygen or air, or another solutions, and make sure you've got enough oxygen there, and make sure the patient's monitored appropriately. Now, the last thing with that is, so you deliver it, get your advice about how to deliver nitrous safely with oxygen, make sure they're being monitored, and then on the way out, so once you've stopped the nitrous, make sure you keep the oxygen on, because there's this thing called diffusion hypoxemia, and that's really quite dangerous. So the nitrous is washing out very rapidly because it's faster diffusion in high volumes than oxygen, displaces all the oxygen. So now, your lungs are essentially just filled with nitrous without any oxygen, and that can cause this thing called diffusion hypoxemia. So make sure your patient has Hudson mask, 6 liters per minute oxygen, or some kind of oxygen, and they're monitored as you're finishing your sedation with nitrous. I think that's probably the most essential things. Everything else is getting in there, learning how to do it, asking your supervisors how to use nitrous effectively as a sedative.
So I guess in the spirit of completion, what are some contraindications for using nitrous?
Contraindication of nitrous. So, I mean, first of all, it can cause increased nausea and vomiting, and it can have some inhibitory effects on methionine synthase. So, in terms of cellular metabolism, and it can have issues with that. And then obviously the greenhouse gas effect. Beyond that, I think the major issue, so those things are important, that beyond that, the fact that you can't, you need such high doses of nitrous. So let's say you get a patient who's really hypoxemic and needs a large F5 oxygen. Giving nitrous will mean that you can't fill up the rest of the space with oxygen. So I'd say that's the main issue with nitrous.
Yeah, exactly.
What do you reckon?
Yeah, so I guess the other common thing that you need to consider is that nitrous moves into gas-filled spaces very quickly. So if you have kind of a pneumothorax, a small bowel obstruction, or I think theoretically for inner ear surgeries, you need to be mindful they can cause expansion of these gas-filled spaces. So you're at risk of kind of worsening pneumothoraces, worsening bowel obstructions, and inner ear perforation.
That's a great point. So yeah, any kind of laparoscopic surgery as well, you're not using nitrous. So yeah, anything where there's a cavity being opened up or enclosed, like you mentioned, don't use nitrous.
Yeah. Good. And what about fasting? Like, do you need to be fasted to use nitrous oxide?
Look, I don't know what the latest guidelines in emergency is. I think at lower doses, a patient who's young, fit and well, I don't think they need to be fasted. But I'd probably want to check that with your local hospital guidelines, because any of these medications, they're very potent. There's probably some local guideline to follow about that.
Yeah, I think pharmacodynamically, the effect on upper airway reflexes is much less, which is why we can use them in pregnancy and things pretty comfortably. But in terms of use in other areas, my understanding is in ED, they don't often fast for nitrous oxide, but it would be very dependent on local.
But, I think we're pretty safe to say that you don't need to be fasted.
Yeah.
That said, again, patient very elderly, doesn't need and unwell as well. The MAC requirement is going to be less for them. They may be anesthetized with nitrous, so be very cautious the older patient is and the more unwell they are.
Yeah, exactly. Good. And this is the next one. I think is a drug that I haven't used very often, but you've had a bit of experience with, which is methoxyfluorine or Pentarain.
Yeah.
Can you tell us a bit about it?
That's right. Methoxyfluorine was, very problematic. So you couldn't get enough. And it wasn't efficacious enough to give anesthesia, and long periods of use cause renal failure. So they talk about having maximum usage of methoxyfluorine back in the day was under 2 MAC hours. So running 1 MAC of methoxyfluorine for 2 hours, that was roughly safe in most patients, didn't cause the renal issues. So it went out of favor until an Australian company actually started using it, packaging it with these things called Pentarain. So Pentarain is the trade name. It's this green whistle. And if you ever did sport and got a fracture, maybe the ambos gave Pentarain to you. It's just a really effective analgesic and very safe, didn't cause anesthesia, so you didn't have to be fasted. And it would be enough to get you to hospital without having to give you big doses of morphine. So, I think it's important to be aware of it. Like, for example, knowing that that's an option. It's often not used in hospitals, but there are times when you might be able to call pharmacy because you may see the use of it. And I know in one of the hospitals I worked at, they had a process of using Pentarain for burns dressings. The dressing changes are painful. They're just for a short time frame. You've got pretty sick patients often as well. Have them breathing on that whistle, Pentarain, which is filled with methoxyfluorine, and making sure you don't use too many of them. So there's a maximum dosage allowed. Look at the local guidelines for that. And you can get them through with a bit of opioids maybe and just the Pentarain. And there's definitely other situations that people have talked about their use, for example, in high BMI colonoscopy cases as well. There's been articles about that. And any kind of situation where you just need a short period of analgesia that's really effective. So potentially it'll be used more, but it's just one of those interesting things to know about. Oh, and I mean, also the fact that all of these agents can cause malignant hypothermia except nitrous. So if there's ever a risk of malignant hypothermia, you cannot use any of these agents. Probably the one big thing to talk about in terms of contraindications.
Yeah, exactly. And that actually kind of reminds me, I think something is probably worth clarifying is, all these agents are inhaled anesthetics. And so they're all volatiles except nitrous oxide. It's not a volatile agent, it's an inorganic gas. Mm-hmm. And the relevance of this is that all volatile agents need to be in a really complicated vaporizer to use. And nitrous oxide doesn't. It's stored, again, it's quite complicated how it's stored, but it is not a volatile agent. Bit of an academic point, but I think if you're kind of started to learn this stuff, it's important to know the distinction.
Yeah, if there's any real tech people out there who just love this stuff, like if you look at the design of these vaporizers, it's just, lots of things in medicine and the stuff we're using is such insanely great technology, but even the basics of the older machines, and the fact that they have these, whether the variable orifice, the bimetallic strips, which would bend depending on the temperature. It was just amazing calibrations that these older vaporizers had, but we won't go into that because that's for another time.
That's for the part 1 exam.
That's right.
Excellent. I think that's really good. So we've covered everything, that the main agents. I guess something that's really up and coming, that's very, very exciting and new in anesthesia is Xenon. Do you want to tell us a little bit about Xenon?
I've never used it. As you mentioned, it was one of the closest agents to an ideal gas. It's naturally occurring in the environment, and it's an analgesic as well. But you need, again, large concentration. I think the MAC is 60 or 70%. Is that right?
The max 71%. Yeah.
Yeah, good. So again, same problems. You can't use enough of it if you need high FIs of oxygen for a sick patient. So that's always a problem. And it's very, very expensive. Xenon, for them to, it's naturally occurring in the gas around us, it's very small concentrations. So to be able to extract and manage this noble gas is very, very difficult. I haven't seen it used at all.
Yeah, I don't think it's commercially available. I might be incorrect in saying that, but yeah. So the process of fractionally distilling it from the air is incredibly expensive, and but it is the closest thing we have to an ideal volatile agent. So it has much less. So it's considered to be quite cardiovascularly stable. It has less of the respiratory effects, and it's got the fastest onset. So we were talking about blood gas partition coefficient values. It's 0.14, which is the most insoluble, so the fastest, and there's absolutely no metabolism at all. So it's a great drug, and maybe in my lifetime, towards the latter half of it, we'll be using it, and I think it's pretty exciting that there's still kind of new things we're figuring out to use in anesthesia.
It's funny. I started in my part 1, which was before yours, and hey, still not here, so I'm waiting. I think that's pretty much it.
Good.
Time to wrap up. So again, thank you very much for watching and listening. If you have any questions, please contact us at anesthesiapodcast@gmail.com. And please share with anyone who might be interested, and see you next time. Thanks a lot. Bye.
Thank you. Bye.